Welcome, everybody. It's really wonderful to see so many people here. Thank you so much for joining. Um, Hopefully, you're in the right place. We're here to talk about the COSI study. Um, so, I will kick off with a bit of intros and housekeeping. Um, my name is Camilla Rosan. I'm a consultant in perinatal clinical psychology by background, and I was the chief investigator of this study with my colleague, Professor Peter Fonagy, um, and with an absolutely amazing team, some of which are here today. And it's something we've been working on for, I guess, about 5 years now, a huge amount of time. So it's really exciting to be able to share the results with you today. Most of the results today shouldn't be triggering, but we do touch on some of the kind of qualitative findings, and perhaps what's helpful to bear in mind is that circle of security. Um, Parenting groups do talk about both kind of current parenting experiences, but also um, own parenting experiences from childhood, and perhaps experiences of that may be upsetting or distressing. So some of that may come up. So just be aware of that, and opt out anytime. I also just wanted to share our diversity statement at Anna Freud. And we'll share all the slides with everybody, so you'll be able to have a look at this in a bit more detail. I think something that we wanted to kind of pick up on for the um, purposes of sharing our results is that we, intentionally used inclusive gendered language in the study. So we predominantly refer to parents, um, and when we mean birthing parents, in our sample, they were predominantly people that identified as mothers, but when it's relevant, we make that separation. Okay, so this is the plan. So I'm obviously doing this initial intro bit, and I just wanted to say something about what kind of went on behind the study, what was in my mind when we kind of put the proposal together. Um, to set the scene. And then Kim and Zoe are going to speak about the findings, both from a qual and quant perspective. Sophia's going to share her experiences of being part of the expert by experience panel involved in the study. And then Nick and I are going to talk about the clinical implications and what it might mean for many of you who may be using Circle of Security in your clinical practice. And then we've got time for Q&A. At least this is what we hope we're going to do in terms of time. Um, yeah. So set the scene. So we started thinking about this. For people that know me, I came into my job at Anna Freud from working at NHS England, where I had been part of a group with NIHR trying to put together a perinatal call. And so by the time I left, the perinatal call came out about essentially what the evidence gaps are in NICE guidance and perinatal practice. And so I was very lucky to then be able to apply for this call. And so we did within the HTA stream of NIHR. They predominantly fund kind of full-scale randomized control trials. Um, and uh, and when we were thinking about what we wanted to focus on, because there were so many ideas in my mind, and it's some of the biggest gaps in NICE guidance at the moment, and therefore so pertinent for perinatal teams, is around psychological interventions. And as a psychologist, this obviously chimes. Lots of the evidence, that were used for NICE guidance were perhaps not in perinatal specific populations, or were perinatal but not mental health specific. So we were really interested in thinking about parent-infant, which was a particular gap. But also no groups were recommended. So we were also interested in that. And when we were thinking through parent-infant, circle of security parenting groups were one of the interventions that seemed very well liked, with high acceptability rates in services. People were implementing them. And we did also consider video interaction guidance, which is another really well implemented intervention in perinatal services for parent infant. But we went with the groups gap. And I guess the other gap is that testing in that specific UK context. So how does this fit for our NHS perinatal mental health services? And that's how we came to Circle of Security Parenting. And I imagine most of you here are either trained or are very aware of it because it's delivered in your service. But it was developed originally as a psychoeducational group, but pulling on kind of cognitive behavioural attachment and psychodynamic type ideas, but essentially into a psychoeducational group. But as I said, is that really kind of focuses on early parenting experiences and how they may impact current parenting practice. So when we looked at Circle of Security Parenting, at the time that we put the bid in, there was a systematic review that found a medium effects for reducing maternal depressive symptoms, larger effects for improving maternal self-efficacy, and some medium effects for improving child attachment security. However, most, if not all of the studies weren't randomised, or the ones that had been randomised were really small samples, so they were more like kind of pilot trials or just not powered to really make concrete conclusions, or the quality of the studies was quite poor. So the other big gap was really there wasn't anything perinatal specific, and there wasn't anything that was mental health specific either. Since then, there have been a few other studies that have come out, showing you some papers here. Essentially, they didn't find such strong effects. Kim's going to go on and talk about that a bit more later, but together with the previous findings and the more recent, some of which are perinatal, we are not seeing these kind of same impacts on outcomes in the perinatal period where mental health difficulties are present. One of the things that I was really passionate about trying to do for this trial was to deliver it as pragmatically as possible. I guess what I mean by that is deliver it in a way that it would go on to be delivered in the NHS, so that we're not testing something that is so gold standard that's never going to be practical for anyone to go on to implement in their services. NHS is very busy and messy and complex, and I wanted the study to be in that context. But we tried to, make things as high quality as possible. So just to say briefly about the model that we use for delivery, we had one psychologist deliver each group. They were trained in the full Circle of Security programme, and then they received specialist coaching from Circle of Security International, which is kind of small group supervision after each of the sessions across one whole group. We then, when we delivered it, we had another non-trained kind of supporter to help with the practicalities. So that might be an assistant psychologist or similar in the team who would kind of join to help with, I guess, planning and, well, we delivered it all mostly online. So some of the kind of answering questions and bringing people in. So just to say a bit more about the online, the model that we set up was that the first session would ideally be face-to-face, to really help that kind of engagement and bringing together of the group, and that then ideally another one at some point to kind of hold on to people with that kind of engagement hypothesis in mind, but then the rest would be delivered virtually. We delivered it over 10 90-minute sessions that were weekly, with 4 to 6 parents in each group. All of this was designed because this is what services told us that they were doing. There was a real strong sense that post-COVID, with all the changes to estates, that it was quite impractical to be delivering a 10-session face-to-face group. Also quite impractical because we worked, across the whole of England and many kind of rural geographies. So to bring participants together across these huge areas in terms of travel in one group space would also be quite impractical. And that was another reason services just weren't doing face-to-face groups in the same way anymore. So our research questions were around, does Circle of Security reduce maternal mental health symptoms in birthing parents accessing specialist NHS community mental health services. And that was including treatment as usual, and then we compared it to treatment as usual alone. Um, and then we looked at many other outcomes as well as maternal mental health. We looked at emotion regulation difficulties, maternal sensitivity. We did observational measures for that. Mother-infant bonding, attachment, security, infant development, a whole range of things that Kim will also go on to talk you through the results of. We also did a huge qualitative piece of work that Zoe's going to talk to you about. For an RCT, I think we feel really proud of how many interviews we did with a hugely diverse group of participants with a range of experiences in a range of places, as well as with interveners and other professionals involved in the care. And then lastly, we looked at cost effectiveness. So we did a health and economics analysis as well. Yeah. So I'm going to hand over to Kim now to take us through the quantitative findings in a bit more detail. Kim was the trial manager on the study and an incredible colleague, huge amount of work. She is a developmental psychologist by background and has gone on to work as a senior research fellow for the UK Trauma Council and has got an amazing fellowship now. Zoe was the qualitative lead on the study. She works at the University of Huddersfield, and she's a reader by background and a specialist in perinatal mental health research, and also was an amazing colleague on the study. So they're going to both take you through the results now.
Thanks so much for the introduction, Camilla. Lovely to see so many people here. So I will be speaking today about the findings on the clinical effectiveness of circular security in NHS perinatal mental health services. We've also summarised our findings in an accessible report as well as in a co-produced animation, and we'll put the link to those in the chat if you want to have a look. You'll also find the direct links to the study's published protocol as well as the paper on clinical effectiveness that was recently published in the Lancet Psychiatry on our website. So we had 10 NHS community perinatal mental health services across England that were affiliated with the trial as recruitment and intervention sites. So all these services, they were new to Circle of Security when the trial started, and we trained between 1 and 3 staff members within each site. So most of the 24 interveners that were trained up for the trial, like Camilla said, were clinical psychologists and had prior experience in delivering groups, parent-infant work, or other psychological therapies. So in addition to the standard formal training in Circle of Security, they also received a perinatal workshop, and like Camilla said, 20 hours of coaching. In total, we delivered 51 Circle of Security groups within the trial across these 10 sites. Next slide, please, Camilla. Thanks. So all parents who participated in the trial were under the care of one of those 10 affiliated mental health services and had moderate to severe mental health difficulties, as indicated by a average item score of 1 or more on the core OM. Participants also self-reported bonding difficulties with their baby, as indicated by a total score of 12 or more on the postpartum bonding questionnaire. All babies were less than 1 year old at the start of the trial, and the average age at baseline was only 21 weeks. Ethnicity profiles of parents entering the trial were monitored throughout and compared to local ethnicity profiles across the different services that we recruited from. And this ensured that there was representation relative to our local sites, and to make sure that this was accurate. So we found that our participant sample was reflective of the population supported by these 10 rural and some urban sites in terms of wider demographics, some of which are shown in the slide here. So the most common difficulty leading to the referral to the perinatal mental health service was depression and anxiety, which played a part for about 80% of our participants. 70% of our participants who were randomized to receive Circle of Security attended at least 6 out of the 10 sessions, which was our pre-specified relevant clinical dose of the intervention. Next slide, please. Here you can see our absolutely wonderful team of research assistants who did a really amazing job of engaging parents and collecting so much data from participating families and our interveners. So in total, over 3,000 parents were screened within our 10 recruitment sites, and 371 parents were consented and randomized into the trial. We randomized on a 2-to-1 ratio, meaning that for every 3 participants, 2 were assigned to receive Circle of Security and 1 was allocated to treatment as usual alone. Prior to the group starting, all participants were invited to a baseline study visit, and the Circle of Security sessions always started within 4 weeks after randomization. After completion of the group, around 3 months after baseline, all participants were invited for another study visit, and we followed them up 7 and 12 months later as well. All study visits included questionnaires that parents could self-complete online, as well as an online video call for a parent-child observation. The 12-month time point also included an in-person visit for the strain situation paradigm, which is used to assess child attachment styles. And the children were between 1 and 2 years old at that time. Parents always had the option of completing the questionnaires on paper, over the phone, or in person if they preferred. We also had a tablet library with internet access for those who required this for either the Circle of Security sessions or the study visits. Participation in the recorded play task and the strain situation was not compulsory, and the sample size is therefore somewhat smaller for those measures. Between 60 and 70% of our participants completed our primary outcome at the very last time point, which is comparable to other decentralized mental health trials that have a long-term follow-up design. The research assistants collecting the data on clinical effectiveness were blind to group allocation, so they were not aware of who received Circle of Security and who did not. Participants randomized to Circle of Security were also invited to complete a survey after they finished the group, and a subsample was then invited for an interview, and my colleague Zoe Darwin will speak more about this in just a little bit. Importantly, all participants, those receiving Circle of Security and those who did not, received treatment as usual from their perinatal mental health service, and sites were instructed to deliver that treatment as usual as they normally would have if that parent was not a part of the trial. Next slide, please. I'll show you a summary of the measures that we collected to assess clinical effectiveness of Circle of Security in this population. More information about these measures can be found in the trial protocol or the Lancet paper. But in short, we assessed parental mental health outcomes with the CORE-OM, which is our primary outcome. We also assessed emotion regulation as a transdiagnostic mechanism with the DERS. We looked at both self-reported and observed parenting through the PBQ and the NICHD scales that were used to code the video recorded parent-child observations. And like I said, we conducted the strain situation paradigm at our last time point to assess child attachment security. And then across all of our time points, we assessed child general and social-emotional development with the ASQ. In our next slide, you will find our results. In conclusion, we found no effect of Circle of Security above treatment as usual for any of our outcome measures. We found a small effect on observed parenting sensitivity at 7 months, but even if this is a true effect, it wasn't sustained across time. Next slide, please. As specified in our pre-registered analysis plan, we were interested to find out if Circle of Security worked better in certain groups and perhaps not so much in other groups. But contrary to our expectations, we did not find an effect for these subgroups that are listed here on the left. We did find some statistically significant benefits of Circle of Security for those who reported that either personality difficulties or bipolar was the main reason for their referral to the service. We do need to say that these findings need to be interpreted with great care given the very small sample size in these two subgroups, but perhaps something that future research could look into. Next slide, please. So, like Camilla mentioned, our findings are very much in line with a couple of recent large and high quality perinatal trials that took place in different countries. So, contrary to the early evidence prior to 2020, there's now this convincing trend of the non-effects of circle of security in perinatal populations, particularly for those experiencing psychosocial vulnerabilities. A recent review found that there were no robust effects for either the parent or the child, for families experiencing multiple adversities, although some outcomes seem to improve, like parenting stress and self-efficacy, which are things that we have not measured in our trial. Others have also recently concluded that maybe the 8 or the 10 group version of circle of security isn't suitable for high-risk diets, and that the 20-week intensive individual program might be more suitable, but there's no data as of yet on the feasibility, effectiveness, or cost effectiveness of the intense program. Next slide, please. So in conclusion, based on these findings and when delivered in this format that we used in the trial, circle of security does not show better clinical outcomes for either parents or children when delivered in NHS perinatal mental health services as compared to treatment as usual. And we therefore cannot recommend that this program be included in routine care for these services.
So I just wanted to introduce Sophia. Sophia is was one of the experts by experience who worked on the COSI study throughout. As Zoe mentioned, she was also one of the lived experience qualitative researchers. She also chaired our EDI panel. She is a very experienced participation lead across a range of studies, including other ones at Anna Freud. And she works as an assistant psychologist now in the NHS.
Thank you, Camilla, for that introduction. And hello, everyone. Thank you for joining us today. So in terms of lived experience involvement, if we go to our first slide for that. Yeah, so who are we? So first, I'd like to provide a quick disclaimer here that I'm just one member of a big and diverse panel. We were sort of diverse in experiences and backgrounds, but also diverse in our areas of interest around what to get involved with in the study and the areas that we contributed to. So here you can see all of us, and also our patient and public involvement and engagement lead that oversaw the panel. If we go to our next slide. Yeah, and as I was saying, so there were a range of backgrounds and experiences amongst the panel. So not all of us had participated in the circle of security intervention ourselves, but we all had experience of mental health difficulties in the perinatal period. We also had some members that worked within the NHS as peer support workers. During my time with the study, I also started working as an assistant psychologist. We had members who had their own community-based projects as well in the same sort of sphere. And many of us had also been involved with other studies and projects as experts by experience before, during, and still continue to now after the COSI study has come to an end. And on our next slide, I'll talk a bit about what we did. The short answer would be that we did a lot, and the longer answer would be that, over the course of when we were individually brought into the study, we were able to provide input into most areas of the study that I know of. And of course, I'm happy to be corrected by my colleagues here, but that's what it really did feel like for me. In terms of what that looked like, so we provided feedback on study procedures and documents. Also, we took part in the training of data collectors by providing them opportunities to, collect data from panel members before completing those same data collection tasks with study participants. We formed an EDI subpanel, so an equality, diversity, and inclusion subpanel. We utilised that space to speak about, how we could increase access to different aspects of study participation for participants. I was a member of this panel, and as part of it, we created a video version of the participant information sheet for the study. And we also created a brief training workshop about inclusive recruitment, which was delivered to the study sites. Some of us were involved with the qualitative analysis for the study, as we've just heard, and we were able to provide our input on the coding of participant interview data. Also, some of us were able to attend the trial steering committee meetings, and we were also able to get involved with the dissemination of the study findings, such as by contributing to the literature output from the study, and also things such as what I'm doing here today as part of this webinar. I also provided the voiceover for the video with the findings of the study that some of you may have already had a chance to see. I think those links will be shared. So yeah, moving on, if we speak about what went well. So I feel like the panel worked really well together, and my perspective was that we felt able to speak freely about what we thought about different parts of the study. The environment that we were in seemed supportive enough to enable us to bring our authentic selves to our lived experience involvement. And yes, payment. So I feel that we were compensated very well and efficiently for our involvement, which sometimes it isn't the case with, lived experience involvement. In terms of choice, we were given a range of things that we could get involved with, but also we weren't pressured to get involved with things that we didn't feel comfortable to get involved with. So, for example, I was not a panel member that got involved with any of the task training for data collectors, as I really just didn't want to, as the idea of a recorded play task made me uncomfortable. So although I didn't participate in this part, my perspectives were heard and reflected on. And so I still feel that I was able to contribute in a way that felt right for me. And this mirror here, so reflection. So we were given access to reflective spaces to utilize if we wanted to. To speak about how our involvement with the study may have been impacting us. I, again, did not make use of this opportunity, as I personally felt that I could do this adequately enough with, the colleagues during the study. I already reflected, with them during meetings and just in conversations had throughout the study, although I really did feel very supported just by knowing that I had access to that space. I could use it if I wanted to. Yeah, so I think still just on that slide, I think what really made the difference for me in the study in terms of having lived experience input that was meaningful were the motivations of the researchers, including, my colleagues presenting here today, and also Lani Richards, who is our patient and public involvement and engagement lead, who oversaw the EBE panel. How they all did this or what made them these kinds of people, they're probably better placed to answer. But from my perspective, I really did feel privileged to, be in the company of individuals who were reflective, they were kind, and they were thoughtful. And after speaking with other members of the EB panel, we also felt it was important to say today that the role of the patient and public involvement and engagement lead really did have a significant impact on the EB panel throughout the study, and how we were grateful that the person who held this role, so Lani Richards, brought her lived experience, but she also navigated her role in a very respectful and collaborative way, where she really did ensure that the voices of all the panel members were heard and advocated for. And then our next slide on our learnings to take forward. So I personally feel that the COSI study did a lot of things right. However, nothing is perfect. For example, not all of the panel were recruited at the same time. So the expert by experience involvement was staggered. As I'm sure many of us here today know, many things are decided at the very beginning of such studies and trials in terms of how things are measured and such as outcomes and so on. And I feel that, not having an EBE panel situated at the same time as everybody else, such as researchers, etc., really, it might mean that you're not going to benefit from the viewpoint diversity that a bigger panel of EBE members can give you. If you're recruiting more of them later on. So maybe some decisions might have been different or thought about differently if this was done. Obviously, we don't know that, but that's just my take. And also, expert by experience involvement can be at risk of being tokenistic or performative. And although it can add to a project by saying, we have had lived experience involvement, the quality of this matters. How an expert by experience is left feeling after their involvement matters, and how you're able to co-create a safe environment that's productive for their involvement matters, and how you're also able to integrate their involvement matters. How you navigate challenge from them is also important, I think, and also what an expert by experience gains from their involvement matters as well. So, for example, experts by experience may want to help others at a foundational level, as do, many researchers, academics, clinicians at that base level. But, what is everybody gaining from the project? There might be financial compensation, acknowledgement from your peers, career progression, something to pop on LinkedIn. But what are your EBEs gaining or hoping to gain? The wider team, do they have any assumptions about what the EBEs would want to gain, and what informs those assumptions, sorry. So I guess to round up, I'd say for anybody here today thinking about how to utilize learnings for your own projects, maybe regarding lived experience involvement, I'd say, have you thought about what motivates your experts by experience, but also what motivates you for having their involvement? Are you prepared to have their involvement in all areas? Are you able or prepared to reflect on who has decided what areas are fitting for experts by experience to be involved with? Are you willing to reflect on what you could have done better, how you might respond to challenge from EBEs? And do you have adequate resources to ensure they're compensated efficiently? And can you provide them support should they need it? And if you can say yes, then I think you're doing what the COSI study, in my opinion, has done with their lived experience involvement. And just to say again, as things should be in this space, everything should be a work in progress. But from my own experiences of lived experience work, I think everybody here set the bar very high. And I think they've done a lot of work towards that in the last few years. And yeah, that's all from me for now. So thank you, everybody.
Thanks so much, Sophia. Thank you. And very humbling feedback. And also really important learning. So thank you. So we're going to move on now to me and Nick talking about clinical implications. So Nick Hawley is a consultant perinatal clinical psychologist. She has been involved in running Circle of Security parenting groups in her perinatal service in West London for many years. She was a clinical advisor to the study. And we're going to try and talk together about how we're making sense of the findings and the kind of clinical implications of those. Particularly in the context of the kinds of questions that people have asked us over the last few months when other perinatal colleagues are trying to make sense of the findings, and some of the questions that have, come up in the chat. Oh, right, I've skipped right ahead. Okay. Um, so, Nick, do you want to say hello? You're not coming up on my screen until you speak, unfortunately.
Oh, thank you, Camilla. Yeah, thanks for that introduction, and it's really great to see everyone.
So we thought, I think one of the most common questions that I've been asked, including by the reviewers of the paper, and I don't know if people saw there was a mental health blog about the study, and I think a couple of people have mentioned it in the Q&A as well, is around online. So do we think delivering the group online diluted its possible effects? So as I kind of touched on earlier, my take on this is that what we were hearing from services is that it would be very hard for many of them, although perhaps not all, and perhaps not, services that aren't perinatal mental health services may have different access to group rooms. So people, parent infant teams may have access to family hubs, etc. But for our services that some would only be able to do online, some were able to do some hybrid. And so we were trying to reflect what was done. All of the 10 services that we worked with delivered how they would continue to deliver. And we wanted things to reflect that. Circle of security parenting groups we know weren't developed to be delivered online, but most psychological interventions weren't. And so what we're seeing now in the emerging evidence, particularly since COVID, is perhaps not what you'd expect, that lots of interventions are as effective, some more, from being online. And this is also true of parenting interventions. So a recent meta-analysis found comparable outcomes for parenting interventions online. But I do kind of clinically, I do feel sympathy with that idea, and it makes sense to me why things might feel a bit different. The other thing that's so tricky is balancing clinical impact with engagement. So can we get perinatal families to attend 10 face-to-face groups? Is that actually feasible? And that kind of goes back again. It may be more feasible in some areas than others. And in some of the geographies that we were working with, it really wasn't. And for many parents, for other reasons, for being in the perinatal reasons, getting kind of out and about and going to regular meetings is also not feasible with a young baby. So those are some of my initial thoughts. But what I can say is that what we found, our findings are based on this hybrid, predominantly online model. So our conclusions are on that. So we don't know the answer to if this was delivered entirely face-to-face. Would it be the same? Yeah. So what do you think, Nick?
I think your description was really helpful, and I think it is a very relevant, and certainly I've been thinking a lot about it since the study, the trial results came in. I think there is something different about the delivery, and I think there are both pros and cons to online delivery. I think certainly in clinical practice, we had a big learning curve when we moved online, particularly delivering circle of security online, that actually people spoke very positively about the ability to get to the sessions. And many families told us I wouldn't have been able to do this if it was in person. So I think it's not super clear, but I think there are pros and cons to both. I would also say relationship capacity, I think, is slightly easier in a face-to-face setting. I think somebody commented about the ability to stay behind after a group session in person in the Q&A, which I think is a really relevant point, that actually there is something that one can notice in another person easier. And that might be something that was lost. What I would say, my opinion is, I don't think we could confidently say that if the group was delivered face to face, we would have seen different results. I don't believe that kind of with confidence, but I do think it throws up some thinking for services to do about what is lost when we deliver online, and also what is gained, and trying to work with the local population, bearing in mind there are lots of different factors to consider. Socioeconomic factors are huge in terms of travel and getting to appointments that we can't overlook. So I think perhaps there is a relational quality that is different in online, and certainly that was reflected in Zoe's brilliant work in the qualitative research that probably is important to consider, but I'm not confident. I wouldn't be confident to say that I think that would have changed things enormously.
Thank you. I think slightly connected to that, I was just thinking about the work that we did on intervention fidelity, which Nick was very involved in. So we did measure intervention fidelity together as part of the trial. As trialists, it's quite a nerve-wracking thing to have people that are newly trained in an intervention deliver it. You want it to be the highest quality that it can be. But for clinical equipoise, we were very strongly recommended by our funder to ensure that every site we worked with hadn't introduced circle of security parenting yet. And what I mean by clinical equipoise, if you're like me, I didn't know what that meant until they asked for it, so I had to Google it, obs. So it just means that people aren't overly invested in it in the service, essentially. They're not coming really trained, really involved. Perhaps like Nick, if we'd asked her to be a trial site, so we're working with people that are naive to circle of security parenting, but that means that you are like, they're not that experienced in it, and so are they going to be the best that they can be? So to help manage that, we invited all of our practitioners to film themselves when they were delivering these groups online, and then we analysed those videos according to the kind of key components of circle of security parenting. And Nick was part of that coding group. So I just wonder if you could say a little bit about that process, Nick, and what we found.
Yeah, sure. So I think it was a really important part for me of the trial, because I think certainly what we really wanted to be sure is that these families are receiving COS in a recognisable form in the way it's intended to be delivered. So we practitioners were asked to film their sessions, and we looked at 28, so each facilitator, we looked at 2 of their sessions randomly across the sessions delivered. So we saw a range of kind of session 1, session 2, session 10, because the content is a bit different. And what we did, we created a scale that looked at the delivery. Were these core components in terms of content, but also the style of delivery? Were those elements visible in the videos we looked at? Myself and a colleague who I think is here today was part of that, looking at those videos. Actually, I have to say, I was nervous to look, because I was thinking, gosh, what if we look and actually it doesn't look recognisable? My actual overall impression was that intervention delivery was very good, very, very good. So we had a cut-off score to say that actually if a session was scored, rated independently by myself and colleague, and then kind of coming together to look at the scores together, if that was above a cut-off, then we would deem the session to have been kind of to have fidelity to the model. And actually all of the sessions we looked at had fidelity. So I think that's not to say all sessions ran perfectly and brilliantly and seamlessly. And that's important to note, because that's also not what happens in clinical practice. Something is thrown up, there's a curveball, or something is unexpected comes up. And so there are moments, and I think one of Zoe's participants helpfully talked about a moment that was difficult in the group. There was a rupture and it wasn't attended to. And those, I think, that reflects the usual clinical practice. But overall, actually, the fidelity rating and looking at the videos that were looked at, the quality was high. And I think we can say with relative confidence that what was delivered was recognisable as circle of security and was delivered well. And I think that's important. So in some way, it'd be simple if it actually we looked and it wasn't. We said, it wasn't delivered properly. That's the reason. I don't think we can confidently say that the delivery looked very good overall.
Thank you. And we will publish a paper on our fidelity findings as well. And perhaps because we've co-developed this tool for rating intervention quality as part of the study, also share that if others wanted to come and look at it and use it. So one of the other kind of questions that I guess asked, or themes that have come up, is really around positioning circle of security as a psychoeducational tool. and yeah, really understanding more about your thoughts on whether you think it is, Nick, and if it is, where it might fit in the kind of therapeutic journey of someone going through a perinatal service, with the level of mental health difficulties they might be experiencing. Yeah, perhaps if you kick that off, I can respond to some of my thoughts.
Sure. I mean, I think the journey through perinatal services is certainly important, and I think the study really shines a light on some of those things. I think that the findings that looked at actually, emotional dysregulation didn't really change in lots of ways or in meaningful ways across the time. I think probably what it tells us is something about being the right person at the right time in their journey probably sounds a slightly better chance of finding this intervention helpful. That's not to say it's recommended given what the study found, but I think certainly linked to that is the age of the baby. So I think routinely the recommendation is that babies should be at least 4 months when this intervention is offered. And the trial was relatively close to that, certainly with the mean age. But actually still at 4 months, babies are, I mean, I say this not always, but often still quite small and certainly not moving. And actually, some of the key ideas in cycle security require parents to be able to visualize this movement kind of in and out of connection and relationship with parents, being able to go away and come back. And actually, some of that is much more difficult to see. And interestingly, I think online, it is more difficult to help parents see that even if they've got their babies with them than it is when you deliver face to face. But actually, I think what may be interesting is if there could be a further look at what happens if actually the age of the baby is shifted and actually much closer towards the end of people's journey in perinatal services where babies are older and on the move, and maybe even beyond perinatal services, but certainly at the end of a perinatal journey, we think, my sense is perhaps there is something that is more digestible for parents to be able to see and to be able to hold on to. And it gives an opportunity to be out of the kind of those sort of early months, which are often really dominated by feeding, changing, sleeping, the framework of one's mind at that point is often on those processes. And as that becomes kind of more familiar and more routine and babies develop in a different way, perhaps this intervention is easier to kind of think about and use for people.
Thank you. It's so interesting, isn't it? Because some of the themes that you shared came up in our qualitative work too. And we did include age of baby in our quant analysis, and we didn't find anything, which we were so surprised at, both in terms of people with older babies benefiting more from the intervention, but also whether they were first-time parents or not. Because sometimes, anecdotally, we were hearing that even if your baby was young, if you'd had a baby before and therefore it was easier to imagine them as a kind of mobile, semi-verbal individual, that some of the aspects of the group might be easier to put into practice, but it just didn't play out in the stats, which we were so surprised about. Yeah. And similarly, the other thing that's quite confounding about our results is that there was a real strong theme in the qual as well about that perhaps people wanted their mental health difficulties to be addressed first, some period of stabilization that you're kind of also alluding to. At the end of the perinatal journey, babies are older and perhaps mental health difficulties are more stable. But in our findings, we found, again, as Kim caveated, a really small group in terms of numbers, but we found those with the personality difficulties and bipolar that was our only clinical statistically significant finding, which again isn't what we thought. It certainly wasn't what the intervention developers thought. So it's difficult to make sense of.
Yeah.
And in terms of psychoeducation, I think although it was developed with that in mind, perhaps as Zoe sort of described in the qualitative findings, when it's delivered by an experienced psychologist to people with complex difficulties, with a lot of shock music, a lot of early childhood difficulties that are being triggered through their own parenting experience, it becomes more therapeutic. What do you think about that?
I think that's a really very, very interesting and valid point, Camilla. And I also to say, I think some of the results do feel very difficult to make sense of, but even particularly because the trial was of excellent quality. So it isn't that I think there's anything obvious that has led to those results being kind of, surprising, I would say, and surprising and disappointing, I think, for lots of people, myself included. But the quality was excellent. So I think, I mean, I wonder whether there is, obviously the numbers are small, but whether actually I guess there is for me, there is a hypothesis about people with personality difficulties that perhaps there isn't such a kind of changeable picture where in that perhaps some of the personality difficulties are more stable, perhaps with sort of the usual ebbs and flows, but whether there's something about that clinical picture that meant people may have been going into the trial without, or going into the kind of intervention not necessarily in a kind of current or acute kind of mental health that's necessarily different to a usual presentation, but certainly I think there is something important to consider about the use of other interventions perhaps before or sequencing that could also be important. So I think the use, for example, if we're thinking about trying to sequence, whether we're thinking actually are we trying to use other interventions, like, for example, some of the DBT adapted interventions to support with emotion regulation, to allow people perhaps to feel that their own mental health, their own emotional well-being is in a kind of a good enough spot or a better spot that allows a different experience of circle of security. But again, I know lots of this was looked at, and certainly all of that was kind of considered. But I think it certainly means what was happening routinely in NHS services of the circle of security being offered quite early in the postnatal period to a kind of a sort of large number of people, regardless, apart from people in crisis generally, actually perhaps that needs to be really, really reconsidered.
Yeah, thank you. We're coming to the end of our time before we move into Q&A. Is there anything else that you wanted to share based on your own clinical experience and making sense of the findings?
I think the other thing, Camilla, that's really stood out to me and is, I think, some of the things that we sometimes think people may get from interventions, we may just be not quite right on that. So I think in the perinatal period often is a time of great loneliness and isolation, and actually whether there is something about togetherness, connection, being with others that actually is really valuable and important, but perhaps doesn't show up as in some of the ways that are measured. And I think that doesn't necessarily have to be a circle of security intervention, because that's quite specific, but actually whether some of the anecdotal kind of evidence actually speaks to people's experience of finding it helpful to be often with their baby, with others, thinking about their baby, the experiences they're having, but more so doing that with others and not feeling alone. And I wonder if actually a lot of what we may see people experience, and when people report finding things helpful, whether actually some of what they're speaking to is that.
Yeah, thank you so much. That is really helpful. And I think in some ways also could possibly connect into where it sits in the sequencing of the journey. So if someone's feeling more stable and able to then come to a group and start connecting and forming a kind of a tribe or a community around them, as they then are moving towards discharge from the service, I can see the benefits, like of any group though.
Exactly.
And some of Zoe's results around the flamingos, and we found out what I did anyway. people might know that a group of flamingos is a flamboyance, so that you find this kind of flamboyance of your peers, and that can be really powerful. And that some people were still reporting that in this online group setting. But I think if there was anything that really stood out to me about online versus face-to-face, it's potentially that not being able to have those informal over a kind of cup of tea and a coffee and the after the group chat that you might have. Yeah. Okay, thank you so much. It's been so interesting. So I'm going to invite everyone to turn their cameras back on, and we will try and go through some of the questions. Thank you all so much for all your interesting questions. So we have been trying to answer some of the kind of quicker ones where it's easy to signpost to something or highlight what we did on a measure or something like that. So if people go to the Q&A function, you can see those that are answered and those that are open. So one of the first questions was around whether we've got any data outside of NHS perinatal services where there isn't a diagnosis of moderate to severe, which I can answer quite quickly, is that we don't. We are only really here today talking about what we found in our study, which was only with those with moderate to severe mental health difficulties. I know that there'll be lots of people here that might be delivering in parent-infant teams or in family hubs or other services. And I would encourage people to have a look at some of the other trials that we highlighted in the introduction, to read through them. Quite a lot of the previous evidence base wasn't, in fact, on the risk of parental mental health difficulties. It was on other risk factors to do with kind of other indices of deprivation or social disadvantage. And some trials were done on kind of levels of attachment difficulties in the child, or some kind of child behavioural problem or something like that. So yeah, that isn't what we looked at, but so you can't generalise our findings outside of NHS perinatal mental health services, but I hope it would certainly make you curious about them. Yes, we've said a bit about what treatment as usual was involved. It's in the supplementary material of our Lancet paper, so please go and have a good look at that.
Camilla, if that's all right, we do have a slide, because we haven't talked about it, and I'm realizing that multiple people are asking. We do have a slide on what treatment as usual across our 10 sites combined included. That doesn't tell you what individual people received, but it does show the width, probably, of what people could have accessed. So perhaps that answers some of the questions.
Thank you, Kim. Just to say that perinatal mental health services are very well resourced. We are doing a lot, and that's also why our findings are so specific to our setting. And I guess what we found was that in addition to what people were getting, Circle of Security Parenting wasn't providing any added benefit on all the things that we measured. And I think that's what we're kind of inviting. It's food for thought. We haven't our economic evaluation, which has much more detail on this, is still under peer review. So yes, people will be able to read more about it when that comes out. Essentially, what we can say is that when we looked at our COS-P arm plus treatment as usual and treatment as usual alone, we couldn't see any meaningful difference between those arms in terms of what treatment as usual people got, and particularly thinking about the parent-infant interventions. So you weren't any more likely to get, say, baby massage group or video interaction guidance in the treatment as usual group if you would also receive Circle of Security Parenting. So the arms were fairly equivocal in the analysis that we did. Collecting treatment as usual data well is very, very difficult, and was very difficult for us. What people say that they got versus what services say that they got versus what they might have actually got are in a Venn diagram. So we did a lot of work and co-produced how we collected that data very early on, but it was still very difficult to analyse, and particularly for a service like this where so many different types of interventions were offered, how much people engaged with them when they did is just very complex. So I invite everybody here to develop better methods for collecting treatment as usual data. Right, I definitely need to hand over a question now because I've been talking for too long. So I just wonder if people are able to share any reflections in general about the outcome measures that we use in our study, and anything that you think went well, or perhaps what was missing, or what you might have done differently. Any thoughts? Kim,
I
you
can
can
say
say
something, I
something, I'm
don't know how
sure.
interesting it is. Yeah, I guess, I mean, around that treatment as usual question, tying into where people are on their treatment journey, and also some of the questions that have been coming up around diagnoses. I'm biased, but I think we did a relatively good job of looking at this with the transdiagnostic lens of what are people struggling with and the commonalities in that across parenting and early childhood and things like that. But I think looking back, it would have been helpful to maybe understand a little bit more. And I don't have a great recommendation of how to measure it, and that's the hard bit. But to understand where people are in their journey in terms of how long they've been under under that service for that particular time, what kind of treatments have they had before, and importantly around the childhood maltreatment, which we thought, or at least some of us thought, would play a big part in this, where maybe people would benefit more if there's something to benefit from, but perhaps there's a cutoff at some point that if sort of in more complex scenarios, especially if people haven't had support for that prior, that would actually make it a lot harder, so that there maybe wasn't a straight line to draw there, but that is more of a complex relationship. And we haven't really, there's some clues in that in the qualitative, but in the quantitative definitely haven't found that in the way we thought it was going to work out. But there are some unknowns in terms of what kind of support people have previously had, how helpful that was at that moment. Did they just come out of a therapy that they found super helpful? Were they at the very beginning? Were they actually on a waiting list and hadn't received any support yet? Then were just sort of thrown into this group, would may have been sort of too much or too soon or too unsupported for some, and for others was a perfect balance to where they were in their lives. So it sounds a bit messy because I don't have a suggestion of how we could have quantified that, if there is any, but from everything we're hearing and seeing in the data, I think it's a really relevant one, and it might help us to have a better idea of when and how to introduce programs like this and how to support people throughout it. And there just aren't great ways of doing that at the moment. We're using measures that just don't directly examine that, but they're more sort of on the periphery, and it's all related, but it's complex and we're not really getting to the core of it. If that makes any sense, Camilla.
Yeah, thank you so much, Kim. I think my perspective is that I don't know that it would necessarily have changed the results in any way, but I am really curious about our screening. I was always a huge advocate for observational tools around understanding parent-infant relationship quality and really zooming in on the construct that you want to understand. And as part of identifying the most at-risk group for an intervention. And I felt like perinatal services were very, very far away from doing that as a standardized screening measure at intake, an observational assessment that's then coded. But I think this is a fundamental issue in our practice. If we are going to have robust parent-infant pathways, there are lots of difficulties with parent self-report measures, and they are in many ways unreliable. And so I think I I think, if anything, this study has made me even more sure that that's what we need to do. We need to just, if that's, if we are committed to doing parent-infant work, we need to embed observational tools. We need better observational tools, but we are not going to understand what's going on in a parent-infant relationship without them. And yeah, so we coded we collected so much parent-infant data, and I have so many ideas about what we'll eventually go on to do with that. But we coded it according to the NICHD sensitivity scales, and I would really encourage services to think about how they do that, and really think about what different parent-infant interventions they offer and what aspect of the relationship that they're trying to improve. So, why would you give somebody, VIG versus COS-P versus parent-infant psychotherapy? And what is it in that initial screening and assessment that shows you that person's levels of difficulty require that intervention? And I think that would help kind of clinically pragmatic trials like ours be able to be as focused as possible on the right populations. Yeah, yeah. Did you want to say anything about that, Nick? You were really kindly nodding. No.
Yeah, I mean, I'm not nodding because I think Kim and you and I have had several conversations about exactly what is it we need to understand to get people kind of into the right intervention for them. And I think even with circle of security, and somebody asked a question very recently about some of the limitations. Has that had an impact? And I think in routine clinical practice, I think without us really thinking about it, lots of work happens towards somebody going into an intervention that actually then deviates from what the intervention is itself. So if somebody's having a lot, for example, several assessment sessions, formulation sessions, supportive sessions outside of an intervention, which I think does happen quite a lot, I think what that tells us is actually some people need more than being able to kind of simply see these patterns. They need more help to do something with them. And I think we would be able to find distinct groups who actually can gain real benefit from being able to, for example, just see or have patterns highlighted. And there are another group who I think who's perhaps have more complex histories, who need more support to digest and action those. So I think that's such a thing. I think it's always on my mind in our services to think, what is it? How do we really understand, even within a kind of subgroup of people who may need parent interventions, within that, how do we differentiate even more clearly who needs what? I don't have any answers, sadly. It's just more wonderings.
Thank you so much. I'm going to change tact a bit now. We had a question that I think, Sophia, you might be best placed to answer, if that's all right. Somebody asked, you mentioned about the importance of kind of getting to the root of the motivations of experts by experience involved in studies. And somebody asked how to do that well. Do you have any advice on that?
Yeah, sure. Just look at that question. Yeah, so I mean, in terms of how to get to the root of what EBs want, my first thought is to ask them. But really, I'd say, do they know what they could gain? Do they know what others gain in terms of, others involved in the project other than the EBs, apart from helping to make a difference? I mean, that's just one motivation for many, isn't it? And granted, it might be the underpinning one, but often it's just one. Is anybody having that conversation? I think this is when, that role that bridges between a researcher and lived experience, matters in a similar way to, how a peer support worker could facilitate engagement, they can empower people. Having an EB or PPI lead could help with this. I'd also say I didn't really think about this myself until I was involved with another project as an EB and I was directly asked what I'd like to gain other than helping to make a difference. In fact, it formed part of the funding application for that project in terms of what the EBs were gaining, how they might progress in their personal and professional development. I didn't even know what to say at the time. I hadn't been asked before. I hadn't really thought about what there was past making a difference. But really, if that was the only thing that motivated us in our roles, surely we'd be all doing it for free and pursuing our childhood dreams instead. I think there was also quarterly updates. Could that help to demonstrate the difference they're making? Are there any more impactful ways? I'd say quarterly updates could definitely be helpful in demonstrating a difference. I think a more impactful way is really just comes down to those day-to-day things that I think impact a lot of us at work or when working on projects in terms of how appreciated and valued we feel. Do you feel able to raise concerns? Do you feel that your voice is heard? Are you compensated fairly and quickly for your time, or are you chasing payment? Do you have access to support should things feel tricky? And I think often these things are overlooked. I've come across these issues many times when contributing as an expert by experience. I didn't hear, though, I should say that. But yeah, that's all.
Thank you so much, Sophia. I am mindful that we're winding to the end of our time. There's so many interesting questions we haven't had a chance to answer. So please do get in touch with us if you wanted to speak any more about any of this. We also, in the last week, have been invited by NHS England to do one of their clinical network events in the third week of January. So there'll also be a chance for us to talk again there. But you might not want to come twice. As I was saying that, I was like, I don't know if that's going to be that interesting to people, but perhaps for colleagues who missed today. And as I said at the beginning, we will also be sending out a recording of today. Perhaps one thought that I would finish on around dosage is just that we did do an analysis. I think Kim's kind of highlighted to it in one of her answer questions around whether we saw any kind of clinically statistically significant impact of people that attended more sessions or all sessions, and we didn't, unfortunately. There was a trend of improvement, as you'd expect, but it wasn't statistically significant. But there's also this just tricky balance between that it's hard to get engagement. So there is a more intense version of Circle of Security, a 20-session program that's typically delivered individually, actually, so not in a group. So you kind of then lose the group advantages. But if we are getting an average of 6.5-ish sessions, how is that same group going to do 20? And it might be that individually they are able to engage a bit longer, but often what you see in individual pathways is that people drop out sooner because it's of the intensity of it. So a group takes that away. So I think these are all questions we don't know the answer to, but from our stats, as I can say, we've got a trend of improvement, but it's not statistically significant. But we are seeing that attending 10 sessions is very difficult for a large number of people. So more, I think, would be even more difficult. Yes. So, yeah, I think it's been fantastic today. So many people have come, which is very lovely, and so many interesting questions. And I'm sorry we didn't get a chance to answer them all. But yeah, please do be in touch. So a big thank you.